So today I'll be talking about flanged scleral fixated IOLs and the other flanging techniques. They wanted me to cover that as well. So moving on. So first, I just want to say quickly say how this started. So I was in the theater to start my a case, a dramatic cataract with the zonal dialysis. So I had planned a CTS, and I was waiting for the camera because the camera was there in one of the OTs which had a good camera, and Dr. Swati was doing Swati Upadhyaya from Pondi. She was doing a guard procedure. And I asked her, "What are you doing?" And she was like, "I'm flanging the tip of the proline suture, and we are going to pass it through." So after she did that, I took that suture and I was trying to pluck the knob off the suture, and it was really strong. Then I was, it gave me an idea like, why don't we try doing this? And that's how the flanging technique started. So first I started with the CTS, then I did the iridodialysis repair, and then I moved on to the scleral fixator. That's the order in which I figured out these techniques. So initially we were using the 26 gauge needle. So this slide actually tells the comparison between the conventional procedure and what we have done differently. So we use 26 gauge needle where you dock the suture into the needle, do the sclerotomy, internalize the suture, and then again externalize. Then you have to flange it to the IOL, put it inside an external flanging. Just interiorizing and exteriorizing the suture will roughly take 30 to 40 minutes. Just putting the suture inside and bringing it out takes almost 30 to 40 minutes. So that was time consuming. And so then we asked Auralab to design us a needle attached to the 6O and 7O proline suture, which they did. So the comparison is that when you use a gauge needle, you're going to have a round opening in the sclera. You're going to see a small hole in the sclera, basically. So what Auralab did is they made a very thin spatulated needle attached to the suture. So this reduces the size of the sclerotomy, at the same time reduces the duration. So interiorizing and bringing out the suture should take roughly 2 to 3 minutes. Just the measurement part will take time, whereas doing the sclerotomy or bringing out the suture will take less than a minute. So from 40 minutes to 1 minute. More than that, the size of the sclerotomy is like a thin slit. Instead of a diameter of 400 microns or 340 microns, this is like a thin slit, a rectangular slit where you don't even see the opening. So what is the advantages? When you have to plug a 400 micron sclerotomy, you have to flange a lot of suture, basically around 3 to 5 mm of suture. So you're going to have a very big flange. So flange is basically when you apply heat to the polypropylene, it kind of melts and forms a mushroom. So that's called a flange. So to plug a 400 micron sclerotomy, you have to make a flange which is larger than 400 microns. It has to be at least 500, 550 microns to plug that sclerotomy. Whereas when you have a 250 into 120 micron sclerotomy, all you need is a 150 micron. That size of flange is more than sufficient. So the reduction in the size of the flange, the length of the suture is just 1 millimeter. 1 millimeter of flanging is more than sufficient to plug the sclerotomy. Why is it very important? Because if you are going to flange a little more, you're going to have an elevation on the tear film over the conjunctiva, which can erode over time and it can cause irritation. Whereas when it is just 1 mm of suture being flanged, it is going to be just a small blue dot plugging the sclerotomy. You won't see any tear film elevation, or you won't see any bulge on the conjunctiva, and you don't have to worry about erosion and other things. So moving on to the surgical technique. So this traumatic cataract, where you can see the lens is subluxated. So in these cases, since you're going to make it, you're going to remove the nucleus in toto, you have to make a little larger incision. A proper sclerocorneal tunnel is done. Because if the tunnel is bad, I will not go ahead and do this procedure. It's very important to have a watertight sclerocorneal tunnel. Here the nucleus is gently wheeled and then prolapsed using a vectus. Once this step is done, automated anterior vitrectomy is done. So in this procedure, we are going to position the IOL posterior to the ciliary body. We cannot puncture the ciliary body because it's going to cause a lot of bleeding. So at the level of iris plane, usually it is around 1.5 mm. In myopes, it might go beyond, sometimes even 2.5 mm behind the limbus. You have to customize. You cannot fix 1.5 mm all the time, because if it's going to be 1.5 mm in a myope, you will be in the anterior chamber. So once that is done, we do a sclerotomy. This is the needle that we have designed. So you position the needle where you have to make the sclerotomy, catch the conjunctiva tenons, move them radially, and then do the sclerotomy. So this step is very, very important because at the end of surgery, you want intact conjunctiva and tenons covering the flange. If you are going to do a direct puncture, from the open sky to the vitreous, there's going to be a direct connection. So you position the needle, move the tenons and conjunctiva radially towards the limbus, and then do the sclerotomy. If you do that, at the end of surgery, you'll see that the scleral opening is at a different site and the conjunctival tenons opening is at a different site. So you can be less worried about having an infection. And the reason why conventional techniques, usually it is fixed either at 3 and 9 o'clock or 6 and 9 o'clock, but here you see we are doing it little obliquely. So how we decide where to do is, so when you do this, it is very difficult to bury the second flange, you have to do a peritomy. This is an SICS case where we've done a peritomy already. So I choose the site where the scleral show is more on the opposite side, and then I decide. So in this particular case, the scleral show is good on the right side, no, on the nasal and on the right side. So that is the decision. I will not do it here because it is very difficult to push the needle or manipulate the suture on the left side. So on the right side, we have nice scleral show is there. I can do the surgery comfortably. So if the scleral show is good on this side and it is not that good on this side, I will prefer to do it on this axis. So I'll do a larger peritomy because at the end of surgery, when you're flanging, you want to keep that area dry. You don't want to burn the conjunctiva off. So first sclerotomy is done, and the second sclerotomy exactly 6 clock hours away, you do a sclerotomy. When you're doing the sclerotomy, the most important thing you have to remember is you do not go parallel to the iris because we are so scared of going towards the retina. We tend to go little parallel to the iris plane. Sometimes it might damage the ciliary body and cause bleeding. So you have to go perpendicular to the globe. That is how you have to go. Try to go towards the retina and then you will see that there will be no bleeding. So once both sclerotomies are done, the one that is close to the tunnel is externalized by making a paracentesis on the adjacent side. You dock, so this is a viscocannula attached to irrigation. So I dock the needle into that viscocannula and pull out the needle. Once the needle is pulled out, the needle is trimmed off. Because the main, this is the interiorization and exteriorization process of the needle. The one that is on the opposite side, you can directly dock in through the sclerocorneal tunnel. Beginners, I would recommend you to do it with an AC maintainer. With an AC maintainer, you won't have that backflow of the blood and all that. You won't have that. It is a little safer. So now you have trimmed the needles on both the sutures. The next step is to make sure they are not intertwined. Make sure they are separate right and left. And then the right side suture is taken. I usually prefer not to put down the IOL. I use a lens holding forceps to hold the IOL, pass the suture from above to below through the dialing hole and create a flange so that it is larger than the dialing hole itself. The second was suture, the left side to the left side dialing hole. And again, flange. Make sure you are not going close to the intraocular lens because this is a dry cautery, unlike the wet field cautery that we use. So if you go too close to the lens, the haptics will melt, the optics can also melt. So once the flanging is done and you've made sure that they're larger than the dialing hole, the IOL is pushed into the eye. You don't have to worry that the IOL, it might look as if the IOL is going very deep, but you don't have to worry about that. Because even if it goes, all you have to do is pull the suture through the sclerotomy like how you see in this video, and then the IOL will come back to position. Okay, so relatively very simple procedure, just 1 or 2 cases and the learning is complete. So now once the flanges are engaged below the dialing hole, a mild decentration is created on the transconjunctival side. So always flange the transconjunctival side first because that is easier to bury in the beginning. So 1 mm of suture is trimmed, a flange is created. The mild decentration is to compensate for the thickness of the McPherson's forceps holding the suture. So make sure you don't touch the suture when you're flanging because if you touch the suture, you're going to have sharp ends. So to bury it below the the tenons and conjunctiva, you pull the suture on the opposite side while simultaneously lifting the conjunctiva tenons. So how do you know it is not stuck between the conjunctiva and tenons is when you rub over the flange. You can see the flange. If you rub over the flange with your visco cannula, if the flange is mobile, you can be sure that it is stuck between the conjunctiva and tenons. And the flange is not mobile; it is staying in one place. Then you don't have to worry. It is properly plugging the sclerotomy. So now, before flanging the second site, make sure that you form the anterior chamber very firmly. So now you cannot pull, because if you pull, the flange might break. So instead, you indent the sclera slightly, and then you create the flange. Most important thing while doing this procedure is the surrounding has to be really dry. If the suture is wet or the surrounding is wet, the flanging might take a lot of time. So that's, you can see the time taken. That is because the surrounding area is very wet. So, and then, all you have to do is form the anterior chamber firmly. And then, like Madam said, the dosage of intracameral moxifloxacin is a little higher. 0.7 ml is what the sisters give us. 0.1, little not 0.7 ml. It's 0.2 ml is what they give, because there is going to be a little bit of wastage while injecting. So moving on to so what do we do in cases where the conjunctiva, there is fibrosis, lot of previous surgeries have been done. So we can do the flanged IOL with the foldable intraocular lens as well. So I'll just quickly go through this video. This is what I used to do. I use a 3.2 mm keratome, make a large sclerotomy, and exactly parallel to the incision, I make 2 sclerotomies on either side with a similar fashion where you move the conjunctiva tenons, and the needle is taken out through the clear corneal incision. So it is passed through a cartridge, the butterfly cartridge, and punctured. This is very time consuming, and it's not that easy. So lately what we've been doing is, so we've gone back to the olden days where 20 years back, when we had, when we did not have injectors for implantation of the foldable lens after phaco. What they had was folder holder. I've never seen it. Then I had to ask RK sir and learn from him. So there is a device called folder, which folds the foldable intraocular lens, and then the holder to hold that, and then you put it inside the eye. So that was the practice 20 years back. So now, instead of passing it through the cartridge, it's very time consuming, and there is a high chance the suture can intertwine. It's very, very difficult to do as well. So now what we've started doing is going back to the old holder folder technique. I'll just go through this video. So it's a 3.2 mm keratome with which I make an incision. I make it a little larger so that the IOL goes inside comfortably. So 2 mm behind the limbus, sclerotomy is done using the spatulated needle, and it is done on the other side as well. Both these needles are exteriorized through the clear corneal incision, and once they are exteriorized, so this is a foldable, ideally all SFILs involve a 3-piece foldable lens. Here we use a single-piece foldable intraocular lens because we do not want to puncture the optic. So if you try to puncture the haptic, fixate on the haptic being very flexible, you're going to have a little bit of torsion, a little bit of tilt. So the optic-haptic junction is the best place to puncture, because it is not going to disturb the optic. At the same time, it is going to be a very stable place. So the optic-haptic junction, you hold the forceps close to the optic-haptic junction, because if you are not holding the forceps away and trying to puncture, what happens is the IOL is so flexible, it will just fold instead of puncturing. The needle will not puncture it. So wherever you are going to puncture, hold the forceps right close to it, and then puncture. So this is the folder forceps with which you fold the intraocular lens. So this is what I did initially, because the haptics have no role. They are positioned very posteriorly. People were asking if the sharp edges will damage the iris. So we are positioning it behind the ciliary body. You are going to be really, really far away from the iris. So you don't have to worry about it. So you, with the folder, you fold the intraocular lens, push it inside the eye. The only difference between the PMMA technique and the foldable technique is that in PMMA technique, you finish the vitrectomy and then you start your flanging procedure. Here, you flange, you put the IOL inside, and then only you have to do your vitrectomy. Because if you are going to do the vitrectomy in the beginning, the eye is going to be very soft and it is going to be nearly impossible to push the IOL inside. So this is relatively very simple. This is what I do as a secondary procedures. So when do I do this procedure? When the conjunctiva tenons is very fibrous. So if it is a paying patient and the patient wants a foldable intraocular lens, a better lens, we use this technique. And last week also we had a case where a temporal clear corneal incision was done. It was done elsewhere. The cornea was very bad temporally, and superior sclerocorneal tunnel also was done. It was pretty bad. So what we did is we went to the opposite. It was a right eye, so we sat on the left side, made a nasal incision, and very comfortably we could do. Though it was a deep socket, it was very easy. You can make incisions whichever side and do it. And the one common problem or question that everybody has is the IOL going to be stable or is it going to be moving inside the eye because it is a 2-point fixation. So it doesn't move as you see in this video unless disturbed. Unless you touch the optic, the IOL is not at all going to move. It's going to be really stable. Don't have a video of the post-op thing. I think I added for future presentation. The IOL is very stable. So unless there is going to be a big trauma or unless somebody is going to touch the IOL, you don't have to worry about the wobbling of the intraocular lens or tilting of the intraocular lens. The one good advantage of this procedure is that it is well tolerated. Mild decentration, mild tilt is very well tolerated because you are going posteriorly, you are positioning the IOL posteriorly, which is going closer to the nodal point. So all these things are well tolerated and we have very good post-operative visual results. The one thing is when you are choosing the intraocular lens, always choose an intraocular lens power which is 0.5 diopters more than what is there in your biometry. If it is going to be a myopic patient, I will increase the IOL power by 1 diopter. So moving on to the zonular dialysis management, normally we do a CTR to manage small zonular dialysis. When it's going to be a larger zonular dialysis, we need to do a capsulotension segment. So capsulotension segment, as you know, is a very difficult procedure where it involves 2 sclerotomies. You have to make a Hoffman's pocket or a flap, and you have to make sure you don't puncture the capsule twice. So with this, with our needle and suture, it is a little bit easier. It is just one sclerotomy. So I'll just quickly go to the step. So once, similar fashion like how we explained, move the conjunctiva tenons before you make the sclerotomy. Here, you don't go perpendicular to the globe, you go parallel to the iris. Because if you're going perpendicular, you'll go into the vitreous. So you go parallel to the iris plane. And then the needle is passed and using a same viscocannula device, the needle is brought out. The flange, so initially what I did was I was trying to put the flange underneath so I thought that will be stable, that applies for all like IOLs and CTS. But there is a challenge where the flange sometimes has to sit between the capsule. No, it shouldn't pull the capsule along. So now I've shifted to keeping the flange on the top and bringing the suture from underneath. So the rule of doing the capsulotension segment is that you don't stretch the bag too much. You're not trying to pull the bag too much. The role of the segment is to prevent the bag from falling down, rather pulling it too much. Because when you pull too much, we've seen cases where congenital gross subluxation, your Marfan's, where you have only 1/3 of the IOL nucleus is seen. We've tried these procedures where the capsular, the zonules and the capsule is so strong on the other side, they fibrose over time and they rip. The CTS rips. Post-op picture, it is just like how you see in this. So I would not recommend doing this in gross congenital anomalies. No, if it is mild subluxation, it is fine. In gross in traumatic, you can do it. However gross it is. But when it is going to be a congenital anomaly, I will not recommend putting a CTS or something. It is better to go ahead with the secondary IOL implantation. In gross subluxation, mild subluxation, it is fine. So you can do this. So there's one case where I could do it on a microspherophakia patient where 2 CTS were placed. But unfortunately, when I tried to do the same on the other eye of the patient, I caught the capsule and so I had to do an SFIOL. So this is also possible. And so there's certain points about the CTS placement is always put the CTR before you place the CTS, or if you're using a CONE, that is also good. And always I prefer to use Viscoat or Orocoat Plus to create some space between the posterior surface of the iris and the rexus margin, and make sure sclerotomy is parallel to the iris plane. And the flange, like I said, beneath the central eyelid is what I used to believe, but lately I try to keep the flange above, only in CTS, because so that there is no pulling of the rexus margin. And make sure the flange is larger than the eyelid before you introduce the eyelid into the eye. And external flanging, like I said, because we use this needle, just 1 mm of flanging is more than sufficient. Just quickly go through this iridodialysis repair technique using the flange. So it's a traumatic cataract with the 4 clock hours of iridodialysis, where first you always anchor the iridodialysis and then do your phacoemulsification or your SICS, whichever is required. So after placing the intraocular lens, the HPMC is washed totally, and then I inject Viscoat or Orocoat Plus, because when you use HPMC, the iris tends to roll into a tube. So when you use the high molecular weight coercive dispersive viscoelastic, it stays flattened. So the extent of the iridodialysis is marked, and where we intend to fixate is also identified. In a similar fashion, move the conjunctiva tenons radially before you do the sclerotomy. Here, the positioning of the sclerotomy is going to be at the level of iris plane. So wherever the iris plane is on the opposite side, same distance from the limbus you choose. The peripheral iris is held using the same needle. A puncture is done, and then the needle is exteriorized through the outside. You don't cut the needle, you reintroduce the same needle through the paracentesis, and then the peripheral iris is punctured. Once it's punctured, parallel to the iris plane, a sclerotomy is done, and then it is brought out. Now you have a loop inside. All you have to do is pull the sutures coming out of the eye. When you pull that, until proper approximation is reached, you create a flange. You trim the suture to about 1 mm flange, bury the first site, and then flange the second site. This is a little easier way of doing ID repair compared to the Hoffman's pocket. I was never a big fan of the. So what I'm showing here is a little interesting, very important. So if you see the opening in the conjunctiva and opening on the tenons, they are at on the sclera, they are at different levels. So at the end of surgery, you can see the flanges are, somewhere here. These are the two flanges, whereas the conjunctival tenons opening is somewhere at the back. So you can, if it crosses the first day, once the conjunctiva tenons is fibrosed and sealed, you don't have to worry about infections. So when you have to do this, all you need is low power cautery to do these flanging techniques. So this works on the dry principle, not the wet principle. Our regular wet field cautery will not work. And then you need this spatulated needle suture, which Oral Lab makes for us. It comes both in 7/0 and 6/0. Advantages of this technique is no peritomy. The learning curve is easier and quicker. The surgery is comparatively really fast and involves no scleral pockets or flaps. So, thank you very much again for the opportunity.